Welcome to another episode of the Wealthy Podcast. I'm your host, Shauna Nairos. I am talking to Dan Colbeck. He is a young man who has lived experience with a major cardiac event. A couple of years ago, he had a heart attack. It came out of nowhere. He's healthy, he's young, and not somebody you would expect to have a heart attack. And unfortunately, Dan's situation is not that uncommon. So follow along today. We have some bonus content also. Dan is a physiotherapist, and he shares a little bit about some prevention and health promotion measures that we can all take to make sure that we're living our healthiest life into our later decades. So very excited. Let's do it. I am very excited to welcome Dan Colbeck to our podcast this morning. Dan is an individual that we have crossed paths with here at the foundation a couple of times because he has a lived experience with a pretty incredible cardiac event. And for those of you that are listening and not watching, Dan is a young man. And you look pretty young.
Relatively.
Yes. And not somebody that you would think of as being a candidate for having a major cardiac event. But he's here today and we're going to chat about it. I don't know about you, but I seem to have noticed that recently there's a lot more healthy young men. A lot of them are kind of in the media because they're professional athletes that are suffering these cardiac events or heart attacks seemingly out of nowhere. Dan's a physiotherapist from Penticton, and Dan had just finished a mountain bike ride with a friend when he suffered a major heart attack. He was just 40 years old, so you are a young man. I would say that's young. He was healthy, and the heart attack came without a warning. Thankfully, Dan was rushed to the cardiac cath lab here at KGH, where ultimately his life was saved with the removal of a major blockage in one of his coronary arteries. You can correct me if I'm getting this wrong.
I had one major blockage. I got 2 stents that night. And then I came back for a third one.
So I actually read in your bio that it was like 3 heart attacks.
I had 3, so 100% blockage, and then 2 80% blockages in my major coronary arteries that were stented.
Wow.
I had, when I arrived at the cath lab, I was transferred onto the, out of the ambulance onto the table or whatever.
Yeah.
And I was talking with Dr. Townley, who was working that night, about biking. He's a mountain biker
Naturally.
too. Yeah. So they were prepping me to go into the cath lab, and they're giving me some anesthetic in my wrist. And he was saying, you'll be here the whole time. You'll be with us, and we'll get you sorted. And then like the lights just kind of went out, and I went unconscious. And so the events I had, I had arrhythmias. So I had abnormal electrical events in my heart. So
did you know that prior to the major sort of blockages, cardiac heart attack, basically? Did you know you had an arrhythmia?
Oh, no, sorry. That was just because my heart was having a heart attack.
Oh, I see. That time.
At that time.
Yeah, it was sort of going like, whoa.
Yeah.
Help me.
So I had the AED on. They put it on in the ambulance.
Got it.
So I think I got shocked 4 times by it.
Wow.
And came to. So I had a code blue in the hospital.
Wow.
With that. Yeah.
Amazing story. And I can't wait to kind of get into it with you. So just a little bit of backgrounder. So sudden cardiac events or deaths in men younger than 50 or women younger than 55 is most commonly due to inherited cardiac conditions. So it's only after your heart attack that you discovered that you had a hereditary risk factor for cardiovascular disease. And this hereditary risk factor or biomarker we can actually screen for. And it's more common than you might think. Dan is going to share about his experience, and we're going to pull back the curtain on, okay, and I'm probably going to muck this up, but I'm going to try premature atherosclerotic cardiovascular disease. How did I do?
Good. Yeah.
Yes.
ASCVD.
Yeah.
Yeah,
Okay.
yeah.
So from now on,
Yeah.
we'll just call it
Yeah.
ASCD.
VD. Yeah.
VD.
Yeah,
Oh, man.
Yeah.
And most importantly, I think we're going to try to get into a little bit more about some preemptive steps that people can take to ensure that they and their loved ones are not at risk. So formally welcoming Dan to the Wealthy Podcast. So before we sort of get into all of it, Dan, we have a bit of a tradition.
Mm-hmm.
Before your heart attack, when was the first time that you really had an awareness of the value of health and healthcare in your life?
So when I was a teacher before I was a physiotherapist. So I went to physio school a little bit later. So I think I was 27 or 28 at the time, and I was on my second round of placements, and I was doing a community rehab placement. And I had one client in particular who was my age, who had a chronic disease. He had MS. And I think when you're young, especially when you're in your 20s, you know, chronic disease isn't really on your mind. Especially, you know, my parents were pretty healthy at that point, and grandparents are still healthy and with us. And you're just living life, right? And then you see someone, I saw someone who was my age, who was, you know, homebound, kind of room bound actually with his disease. And it dawns on you that, we're all
vulnerable.
Yeah, totally. Yeah.
So you mentioned that you were a teacher. I'm curious, what inspired you to get into, like, I guess, a career change?
There are lots of things I loved about teaching.
Yeah.
I taught for 4 years total. Yeah, I taught social studies, high school social studies, and I taught elementary school for a year. I actually had a physiotherapist come into my classroom when I was teaching grade 2-3 split, and pull out this one boy, Steven, to work with. And I thought it was really cool. He couldn't walk up the stairs without, you know, alternating his feet. So he was still matching his feet in grade 2.
Okay, yeah.
His shoes were always on the wrong feet. He was just falling all the time in phys ed class. And so I put in this referral form to physio, and I got this great list of things to do with him and for my whole class, and ideas went home to his parents. And before the end of the year, he was alternating his feet going upstairs. His shoes were on the right feet. He was much stronger. He wasn't falling. His balance was improved. And I just thought, this is cool. Like, this kid's trajectory has changed. He'll probably be healthier when he's an adult. He'll probably have more fun. Hopefully he's probably 20. I don't know how old he is now, but, you know, hopefully he's still active and, you know, enjoying physical activity. So I just, kind of planted a seed, and then,
That's awesome.
Yeah.
And maybe he'll, like, you know, think back on his life and be like, I remember Mr. Colbeck, and I can thank him for being able to go upstairs 1 foot at a time. That's pretty cool.
Yeah. I put stickers, like tape decals, on the stairs, and had him go, you know, just like the physio recommended it, right?
Yeah.
So I was just following the recommendations, but yeah.
It's so interesting, hey, like the things that we take for granted in the human body and the brain body connection is so fascinating. We can maybe have you come back and talk a little bit about that.
Yeah.
I love that stuff. So, all right, fast forward. Tell me a little bit about that day with the mountain biking and your friend, and like, what happened?
Yeah. So it was May 18th, 2022. And I was out for a ride with my friend Travis, and in the Three Blind Mice trail network. And I had a great ride. I finished the ride, and I was coming down. You end on the KVR, Kettle Valley Railway Trail. So we were on that trail back to the parking lot, and I felt the burning in my throat, or what I thought was a burning in my throat. Like
indigestion?
If you've ever gone for a run, like I grew up in in Alberta. And like, if you go for a run on a cold day, like when it's -20 or like, you know, something like that, and you're
No, I have not done that.
okay. Anyway, you get this burning in your trachea, and it's I reckon, anyway, it kind of took me back to my childhood, and I was like, what's going on? It's 20 degrees out, and it's, you know, it's nice. And then I got to the parking lot, and I felt lightheaded and like, you know, not seeing super clear. So I put my bike on the car, and told my buddy that I was going to get a drink of water, and I got to the car and sat down, and just felt like somebody had dropped like a ton of bricks on my chest, and couldn't get my water bottle open. I think I dropped it and spilled the water, and just kind of blacked out for a little while, and just felt heavy and not right. Thankfully my friend Travis came and checked on me and called an ambulance.
What was going through your mind when this was happening? Do you recall?
Yeah, it's funny. Because I don't think I could have called an ambulance on my own. Like, I wasn't thinking critically, you know, at that time. You're just thinking like, this is wrong, and I don't feel good.
Yeah. You know, when something like, I wonder, like, you know, the mind sort of, do you know, like, oh, this isn't good. Yeah.
And then the ambulance came, and I think in the first podcast, you guys were chatting about like a, you know, series of things that took place. So they have an ECG in the ambulance.
Yes, they do.
And that was donated
thanks to
by
donors. Yes.
Yeah, which is amazing. So, so that got me to Kelowna to the cath lab instead of going to, you know, a regional hospital.
Penticton.
Yeah, exactly. Where I wouldn't have had that treatment. So, so I didn't really know until, you know, the paramedic, you know, reads the sheet, and he's like, let's do it again.
Oh, really? And this is in the ambulance, right?
This is in the ambulance. Yeah. And I'm like, hey, you know, what does it say? And he's like, it says you're having a STEMI. He's like, but we're going to do another one in case the machine's not right. And then I thought back to exercise physiology class in school, and I was like, STEMI, you know, tombstones. That's like the ECG prints out.
Oh, is that what it looks like?
Yeah, it's an ST elevation myocardial infarction, and one of the leads on the ECG will make a little tombstone.
Wow.
Yeah, so I was thinking back to that.
You know, they could come up with a different thing that looks like, you know, maybe gap teeth or something like that, you know?
Yeah. Well, it's like, it's predictive, right?
Yes.
So,
Wow.
Yeah. So I was kind of like, shoot. And then off we went.
Yeah. So just to kind of give some background to what Dan's referencing is, when the ambulance came to pick you up, there is equipment in the ambulance that allows the paramedics to do that test, the ECG test, right in the ambulance, which is actually quite remarkable, because normally you would have had to go to Penticton Hospital first.
Yeah.
And the results of that are sent directly to
the cath lab.
Yeah, the cath lab at KGH. So by the time that you got here to KGH, also just going to say it again, this technology equipment was donor funded. Yeah. So yay.
Yeah.
For donors.
It's amazing. Yeah.
Yeah. So you got to KGH cath lab.
Yep.
And that's where sort of all the heavy lifting began.
Yeah. So they're prepped and ready for you because they already have the ECG results. So they know, they have an idea of what's going on, right? And they can intervene as soon as you get there. Yeah. So
pretty crazy turn of events. Did it occur to you, you know, when you were in the ambulance, like, and the tombstones and all that, and the STEMI? By the way, your friends in the cath lab are going to be so proud of you for actually saying what STEMI, what that is an acronym for, because it's a lot. So well done. But was it then that it occurred to you that you were having a heart attack?
Yeah, not until he said, you know, let's do it again. And then let's go to the cath lab.
Yeah.
Then I was like, wow, this is real.
Yeah.
Yeah.
Scary. So in the aftermath, so you go cath lab, you have the stints in put in place.
Yeah.
Is that a surgery?
So they go
Laparoscopic?
Yeah. So I've got like two little incision marks there. So they go
On his wrist.
Yeah. So they go in through an artery in your arm.
Yeah.
Right to the heart. So it's yeah, and then so they have this, and then they have the imaging kind of like right there above you. So they're taking imaging while they have this instrument in your heart, like in the arteries. Yeah.
Another big shout out for our friends in medical imaging. Yay.
Yeah.
And the cath lab.
Yeah. The cath. Yeah. I mean, yeah, it's amazing. Like, yeah, so much gratitude and thanks for Dr. Townley and like the nurses that gave me chest compressions and helped out with with all my treatment. Yeah. So,
in the aftermath, you learned that you actually have heart disease. Is that correct?
Yeah. So they kind of took, it's funny, I was going to have my cholesterol checked 2 weeks at an appointment I had 2 weeks after my heart attack. So they kind of take they do all your lab work, lots of lab work in the hospital was done, and everything was kind of normal. So my HDL was a little low, but not too bad for a 40-year-old male. And my LDL wasn't particularly high. Those are the two kind of common, when people think cholesterol, they think LDL, the bad cholesterol, and HDL, the good cholesterol. And I didn't really have there was no other indicators. So there was a fellow there, a cardiology fellow, who was seeing me, and he said, we're going to check your lipoprotein little a. I was like, what's that? I've never heard of it. He's like, well, it's, it can contribute to heart disease. I was like, okay, interesting. So I'm like, so much time, like you're just sitting like
on the Google.
Which I don't know if that was a good thing or not, but so anyway, that came back, and you don't get it because it goes to St. Paul's where they process it, I believe. So so it came back, I think 3 weeks later. So I didn't know, like the whole time I didn't know what caused these this plaque to build up in my heart till then. And then I think my values were 4 times the normal.
Oh, wow.
Kind of normal. So pretty high. And it's hereditary. So I have 2 great grandfathers on my mom's side that I didn't know about who died of heart attacks before the age of 50.
Really?
Yeah.
But you only discovered that after all of this went down.
Yeah. Yeah.
Wow.
Yeah. So it wasn't on my radar because I knew my grandparents, were okay, and
that's like 3 generations back, right?
Yeah.
Wow. So the next question I was going to ask is if there was a history, and obviously there is, but you had to sort of go back a bit, dig for it.
Mm-hmm.
Yeah.
Mm-hmm.
So let's talk a little bit then about Save BC.
Yeah.
Which is, I'll give another sort of little backgrounder. So once you determine that you had this very elevated, what is it called? Little. I love the fact that the word little is in there. Little lipoprotein A?
Yeah,
little A?
Lipoprotein little a. It sounds cute.
Lipoprotein little A. It does sound cute. So cute.
Yeah.
That can kill you.
Totally. I think they're differentiating from lipoprotein A, like the big A.
The big A and the little A. So the little A is a biomarker. Yeah. And if you have significantly elevated levels of the little A, then your risk for heart disease is higher?
Yeah. So there's a large body of research that shows really high association with, high amounts of lipoprotein little a, LP little a, and heart disease and early death. There isn't a lot of causative research yet.
Right. What goes from like having the little a, like elevated little a protein, and actually having the disease.
So research that says LP little a causes heart attacks.
Right.
So you need a study where you compare 2 groups of people, and one group gets treatment and the other doesn't. And then you can say the group that got treatment had less heart attacks. The group that didn't had more heart attacks. Yeah. So there are 3 studies going on right now in phase 3 trials where they're doing those kinds of studies. To show what I think will likely be causation. So
wow.
yeah.
And in the meantime, what we do know is that you can actually screen for this.
Yeah.
Yes.
Yeah.
So this is what we've learned.
Yeah.
Very cool. So like you've got kids. Thanks, Carly. You've got kids. So your kids, any first degree relative of yours can screen for this.
Yeah. Yeah.
Amazing.
Yeah. Yeah.
We'll talk about that too.
Yeah. Yeah. And LP(a) is like, it's like LDL, but stickier and more inflammatory. So it makes vulnerable plaque. So you can have stable plaque and vulnerable plaque. Vulnerable plaque is more likely to tear open. And when it tears open, it has all the ingredients to form a clot right away.
I see.
Yeah,
Okay.
yeah. So.
And that is danger.
Yeah.
We don't want clots in our heart.
No. Yeah.
I don't want plaque in my heart either. It sounds awful.
I mean, yeah, most people who are, they find plaque in teenagers, right?
Yes.
So it's like, we're all going to have it.
Yeah.
You just want to reduce your.
Yes.
Yeah.
And I'm super excited because we can talk. We're going to talk about prevention too, and I know you're really involved in that area. So, Save BC. So once it's been determined that you have this hereditary risk factor, then you have the opportunity to participate in this program, Save BC. So just a little bit of backgrounder on that. So there's between 500 and 1,000 people in BC that are diagnosed with that big long thing, premature atherosclerotic cardiovascular disease every year. So you're not alone, right? And Save BC is a program designed to help people like you and your families, and also healthcare providers, to better identify and treat and help prevent premature cardiovascular disease and the resulting cardiac events.
Yeah.
So it is now. So Save BC was started on the coast. The initiative was started on the coast in Vancouver, and several years ago, I think it was 3-4 years ago now, it was brought to the Okanagan, thanks to the generosity of a family that actually lost their son. And they learned of this program and the remarkable impact that it could have for people like you.
Yeah, I was able to meet them at the forum.
You did. Yeah. Just absolutely lovely. And so thanks to them, this program is now here at KGH. So this is kind of like, despite the fact that we were just talking about that you can screen for this, we don't have a screening program in BC.
No, yeah, it's tricky. Screening is tricky. There are guidelines that family practitioners use, and they don't actually recommend screening for it. There are Canadian Cardiovascular Society guidelines, and they recommend screening for it. But unless you have a known history, they don't recommend screening until you're over the age of 40.
Oh, really?
Yeah, if you read the fine print.
Right.
Yeah. So I think that'll change probably as these studies come about, because your lipoprotein(a) doesn't change. So your liver makes a set amount from, I think, the age of 5 for the rest of your life. You can't change it with diet and exercise. And there are no meds right now that really impact it.
So you just need to know.
You just need to know so that you can reduce your risk factors in other areas.
So they'll screen, unless you have a first degree relative that has a history of cardiovascular disease. If you're just a regular person, they'll only screen you after the age of 40.
That's what the guidelines say.
Yeah. Okay. Fair.
As far as I remember.
Yeah. I mean, I don't want to say that 500 to 1,000 people is not a lot, but relatively speaking, it's smaller than the risk of just the average Joe or Jane having this is relatively low.
Yeah, I can't remember the stats. There are a lot of great presenters at that forum, like some super smart, intelligent people
Yeah.
presenting on cholesterol and healthcare. Anyway, I feel like it's more common, like elevated LP little a. Like I feel like it's in the 30-ish%.
Interesting.
35%.
Yeah.
Don't quote me on that, but I feel like it was somewhere around there.
Okay. Yeah. Well, we'll
for
definitely look it up. And I'm trying to get one of our cardiac physicians on the podcast.
Oh, okay, cool. Yeah.
Understandably busy, but
yeah.
no, I think it's really good to know kind of what the general risk is. But in this particular case, if you are somebody that has a relative, first degree relative with cardiovascular disease, then, and you're over the age of 40, you would qualify for this screening. Yeah. So, so Save BC, it kind of supports people like you and others with the tools that you need to make sure that you understand your condition and help ensure your family members are screened.
Yeah. So I think it's also a biobank for research.
Yes, it is.
Yeah. So you fill out a bunch of paperwork. They came to me in the hospital and asked if I'd like to enroll, and I said yes.
Of course.
I love research.
Yeah.
And then you fill out all of your family's information as well, and then if they want to enroll too, they can be screened.
Right.
So I'm one of 4. So I have an older sister, a younger sister, and a younger brother, and then my parents. So my mom's LP little a is high, and then my older sister's is as well, and my younger brother's is kind of up where mine is.
Interesting. So they would all be at risk.
Yes. Yeah. For women, it's a little different because, as I understand, estrogen is protective of heart disease.
Correct.
So men, like after puberty, their LDL usually goes up and their HDL goes down. And women usually have a better profile, like cholesterol profile. So their overall risk is reduced.
Interesting. But I wonder if that would change as women enter into menopause because your estrogen levels drop.
Yeah. So there's more events as women age for sure.
Yes. Okay. So it's not just men. It is both that can have this profile. Yeah.
Interesting. Women would probably just see the events later.
Yes.
Later in life, from what I understand. Yeah.
And did you have your kids screened?
Yeah. So they're both high as well.
They're both high.
Yeah.
So now they go into, I know they're teenagers, they go into their, early 20s, 30s with the knowledge that they. Yeah. So what does aftercare look like?
Yeah. So my sister, my mom, and my brother are all taking statins to reduce their LDL cholesterol.
Yeah.
So if you kind of think, if you have, a whole bunch of bad cholesterol, if you can reduce a large portion of it, the LDL part, then the LPA has, there's less overall effect, if that makes sense.
Yep.
Yeah. So you're just reducing your risk.
Okay. And then the kids, they don't take those yet?
Not yet. No. So by the time they're old enough, there may be an LP little a drug that they can take, or a statin, or maybe both. I don't know.
Right.
So yeah.
Fingers crossed. Let's go.
Yeah.
Research.
Yeah.
So I'm just curious, like, has this changed anything for you in terms of like how you move through your life? Are you still riding your mountain bike?
Oh, yeah.
And, like, you can do all the things.
Yeah. So in the hospital, it was, so I didn't know what was like the cause or, and then they check your heart function, in the hospital after a heart attack. So my ejection fraction was around 40% in the hospital.
Say again.
So ejection fraction is the amount of blood that your left ventricle, so the kind of last chamber in your heart, pushes out to your body.
Oh, okay.
Yeah, so it's the amount of oxygenated blood going to your muscles, like your body. So
we need this like to move and function.
Yeah. So normal is like, I want to say 50 and up, 50 to 65. I think the highest we get is like 70% in a really efficient person. Less than 40 and you're getting into kind of like heart failure levels. And after a heart attack, some of your tissue is gonna die, because I think I was an hour and a half
without oxygen
to parts of my heart.
Mm-hmm.
So some of it's going to die, and the heart needs to be elastic to work well. so it fills up like a balloon, and then that elastic tissue helps push out the blood to the body. So if you have scar tissue, it's more like a plastic bag, so it doesn't, get elastic and then push out. So I didn't know what my recovery would be like. Some of your heart also gets stunned, and comes back. So yeah, they have like tissue death, or this like, stunned tissue that comes back. So
like it just needs a minute.
Needs to recover. Needs a minute. Yeah. Totally.
Regenerate.
Yeah, for sure. Yeah. So I didn't know, like that was a tough time. And you're super weak. I was super weak after my heart attack. I slept like for like I was a teenager or more, like, yeah. And then you go to cardiac pulmonary rehab. I went to cardiac pulmonary rehab, the program, and started, it's strange because you're like, you had a heart attack, you've got low function. I've been walking around slowly for a month waiting for my third stent. They send you home and they're like, oh, you've got an 80% blockage here, but like, we'll send you home. You're okay. Like,
just don't go too wild.
Yeah. So, and I don't know if they really know what causes plaque to rupture, but anyway, I was taking it easy.
Yeah. Cause that's the danger part, is when it ruptures, when it ruptures. Off. And
Yeah. So it's got like a thin cap on it. And when that cap ruptures, then it lets out the stuff that forms a clot. Anyway, yeah, so I was super, super weak, super deconditioned and fatigued, and yeah, didn't know what I was going to get back to, really. And you don't have your follow-up echocardiogram for 3 or 4 months after. 4 months after. So I think I had mine early September to find out what my function was kind of going to be. And I'm really fortunate. My function's good. Like, I have a 60 to 65% ejection fraction again. So
wow.
Yeah, so I'm really, really fortunate.
Yeah.
And fortunate that I got there when I got there, and fortunate that I had good rehab at the CP Wellness program. So
do you think heading into the cardiac event, being healthy was helpful?
I think so. Yeah. So you asked what changed. Sorry. Yeah. So I take medications now. So I take statin, and I take a drug called Repatha, evolocumab, which really reduces my LDL, because I can't reduce my Lp(a). So my overall profile is actually pretty good. I'm in a good place.
Right. So you can do all the things.
I can do all the things. Yeah. I went on a backcountry skiing trip this winter. Did like 30-kilometer days, 1,500 meter days.
Amazing.
For 5 days in a row. Yeah. So my things are actually easier now than they were before. Yeah. Like, I didn't really know it before. I was super active, like ski touring and mountain biking and cross country skiing and running if I have to. And so I'm back to doing all of those things, which is great. Yeah.
That's so good to hear.
Yeah.
And I think that a lot of the times when we think about cardiovascular disease or, the type of profile of people that have heart attacks, it's not people like you.
Yeah.
So I think that's why your story is so important to share.
Yeah. Our diets, people often think diet. I'm married to a dietitian.
Wow. Your house must be fun.
For 20 years. No, it's, I'm
I would love that.
But so we haven't really changed too much diet wise, maybe a little bit more like Mediterranean diet leaning.
Yeah.
Now. And I definitely, I've cut out some things that I would eat before that are, so I really watch my saturated fat intake.
I see. Okay.
Even though my medications do most of the heavy lifting, I still feel like it's something that I can control and feel good about. So
absolutely. Yeah. But I think the point is that, you can be healthy.
Yeah, totally.
Really healthy.
Totally.
And still you can't sort of undo hereditary risk factors.
And the hereditary risk factor you carry your whole life.
Yeah.
Unless you treat it with a medication. But so like a smoker, for example, will carry their risk factor of smoking for the time that they smoke, but you can stop smoking.
Yes.
So it's a big one. And I'm trying to remember back to the Save BC presentation. there was a slide that showed the risk factors, and I believe hereditary was the same or more than smoking.
Yeah.
If I remember right.
I think you're right, actually. I think I did see that slide. Yeah. So I guess the point is that if you're listening to this, and you have a family member, first degree family member. So by first degree, it was like direct, sort of like an aunt or uncle, brother, cousin.
Yeah, I think for SABC, first degree relative is like parents or siblings.
Parents or siblings.
Or kids.
Okay.
Yeah.
Okay.
Yeah.
Okay.
But,
so.
Yeah. But I don't know, because I mean my history goes back to my 2 great grandfathers, and then like my younger sister, her healthy little A is totally normal.
Yeah,
like
isn't that interesting?
Yeah. So it just kind of depends on how it's passed.
The luck
down,
of the draw.
the gene. Yeah.
As they say.
Yeah.
But one of the things that we did learn at that forum, and we'll post some links to this, is that if you do have that first degree relative with a history of cardiovascular disease, that there is a letter that you can take.
Yeah.
And we do have this available. It's online. It's public for public consumption that you can download, print off, and take it to your healthcare practitioner, so your GP or whoever you're seeing.
Your nurse practitioner. Yeah. They, our primary care providers are responsible for so much. It's tough to stay up on everything, right?
Totally.
So lots of them may not know what LP little a is. It might not be on their radar. So taking the letter is super helpful. Yeah.
And the letter's awesome because it actually just it frames what the risk factor is, and also provides just a little bit of direction as to what the tests need to be. So anybody that again falls into this category of first degree relative that has had cardiovascular disease can take this letter to their healthcare provider and request the screening. Which is amazing. So the forum was actually to invite the public and then also clinicians to learn about the little a. The little a. And then the screening protocol around that. It's very, very awesome. Okay. I want to talk to you about prevention. And I know that's something that is an area of particular interest for you. So let's talk about that.
Yeah. So I think I've always been like talking about Stephen when I was teaching, so I've worked with pediatric populations for a lot of my career as a physio. And it's neat. To see that impact and the change in trajectory. But I also think about it when I'm working with older people. And then I think about it for myself. Like if I could have had my cholesterol worked up when I was 20 years old and started on a statin and avoid having a heart attack and, all the rest, then that's preferable.
That would have been great.
It would have been great. And I mean, great for me, but also great for our system. Because my, 3 or 4 night stay in the cardiac ICU wasn't for free. And, the cath lab isn't free and, all of that, the ambulance ride, all that stuff. Right. So, so I think it's important to be good stewards of healthcare. And I think, if you can be preventative, that's being a good steward for the system. So, acute care, like the reactive care, is amazing. And obviously I'm very thankful for it. I think it's a great system. It's refined, but it doesn't work well when it's, stressed.
Exactly.
So I think if we think of healthcare kind of as a 2-sided coin, you have like the acute reactive care on one side, and then you have prevention or population health promotion on the other. And I think you need both to have a good system. So
we totally agree.
Yeah. So I think that's why SABC is very cool. And I think you mentioned it on the first podcast, we're not just about buying equipment. There's to be innovative and think of, new ways to have impact. You got to think, maybe think
upstream.
Outside the box a little bit, right? Think upstream.
Yeah.
So SABC is very cool because, hopefully my brother and my sister and my mom, won't have heart attacks. Right. So,
and your kids.
And my kids. Yeah. And actually I have 2 friends who got theirs tested. One lost her brother to a heart attack at the age of 43, I think. And she's taking a statin now too, because her Lp(a) is high. And then just another friend who has heart disease risk. And his is quite high too. And he's taking a statin as well. So
Did they get tested because of you, or was that just, they did.
Yeah. Like kind of as I found out more, and
awesome.
Yeah. So, so I have, so I love prevention. I just find it interesting and fascinating. So I have kind of 3 kind of case studies or kind of real world examples of it that I was hoping to just chat about.
And quick. Is this prevention like just with, for example, like for heart health in general, or?
Like some yes, and some broader than that. Yeah. Okay. So, so the CP Wellness program, the cardiac pulmonary rehab program that I went to, in Penticton has a fantastic program. So they fundraised for like commercial grade gym equipment. So they have resistance training, like a whole circuit that you can do with amazing equipment. I think most programs have TheraBand, which isn't the same.
Right.
And they have a whole bunch of machines as well. So they have bikes and treadmills and different things, and adaptive equipment too, for people who might not be, they have arm cycles and things like that too. So and then so you go for an hour and a half 3 times a week for 8 weeks. So that's long enough to kind of change some behavior.
Oh, for sure.
And you're going with your peers, even though everybody was, I think, 30 years older than me who was there, you still get to know people, and but there's people checking their blood sugars. There's, people with oxygen tanks. There's so it's, to go to a gym or a community center is you might not feel comfortable there if you have a chronic disease. Mm-hmm. You're not seeing yourself, in the crowd. So I think it's tougher to get in there, but this program is super inclusive. It's preventative in that it keeps people from having a second event. Yeah. And it does a good job of that. They have a program that is more upstream. So there's a risk reduction stream, but there's never really spots because there's always so many people who are in the post-event group
category.
Yeah.
Wow.
Yeah. So there's just not really capacity for it often, as I understand. So, so that was a great program, and your confidence is really low after a heart attack. So even as a physiotherapist, you're not really sure what, even though you're taught the heart's a really tough organ, and you gotta, everything you gotta use after rehab, you always use it. You use your body, but it's tough to do. It's
scary.
Totally. You don't trust your body on some level.
Yeah.
So having the staff there, it was awesome.
Mm-hmm.
They're we've seen you, this is okay. You got to do this to get better, to improve that ejection fraction. And then just little by little, incrementally, you kind of get better and better and better over the weeks. Right. And you see your progress, you track everything, and it really instills confidence and builds habits. So when you asked how things have changed, I don't before I was kind of on and off with weight training, and now I don't miss, I'm, twice a week. I'm in the gym. Yeah.
Wow.
Yeah. So, it forms habits that you can keep, and they have a maintenance program as well. So after you've finished, the CP wellness program part, you can go into the maintenance program part, which is cool. So people kind of keep their peer groups, and they go and can kind of keep up that maintenance.
And how did you find these friends?
So actually I have a friend who is a physio in the program. So I've kind of always known about it. Yeah. And my wife is a dietitian, covered in there a little bit. Yeah. So I've kind of just always known about it. But that kind of leads into my next example, because navigating the healthcare system is hard. So if your cardiologist doesn't refer you, you might not know that a CP wellness program, I mean, I would assume that most are referring, but you have to know where to go and how to get there.
And CP, is that
cardiac pulmonary rehab?
Great. Yeah, that's what I thought.
Yeah. So, so kind of the next example is the Seven Oaks. There's the Seven Oaks Hospital in Winnipeg, and they have a world-class wellness institute attached to the hospital. So they had a generous donor donate, I think it was $25 million or something like that. And they
Wow.
built this wellness institute. And if you kind of think of taking a community center and combining it with all of the outpatient programs that exist in a health region and putting them under the same roof. So it's no longer like, oh, I go there for this and I go there for that. And
It's
I need a
all
referral
in
for
one
this to there.
place.
It's all in one place. So it takes away that navigation piece.
Yeah.
It also makes it easier for our primary care providers to just say, here's a referral to the
Go there.
Go there.
They'll help you.
Yeah, and when you go there, so everybody who leaves Seven Oaks Hospital gets a referral to the Wellness Institute, and they have lots of research going on that shows a reduction in hospital visits.
Wow.
With that institute, and as I understand, it's quite cost effective too, and they have research that shows that as well. And where I see the value, like as a physiotherapist, so I work with a lot of people who fall, like elderly, people over the age of 65, and the cost of falls in Canada for that age group is about just over $10 billion a year in 2021. So now it's probably like $20 billion with inflation. But yeah, so I did a scan of kind of exercise classes in our area in the South Okanagan, and none of them meet kind of best practice guidelines for a falls prevention class. So, So solving falls isn't a mystery. Like, we know if we change the environment and improve capacity, people stop falling. But it's a tough problem. So if somebody has a fall and I say, you got to work on this and this and this, like, you should go to a class because that will, support you, and it's supervised. And, but there isn't one that exists that kind of ticks all the boxes. So if we had this wellness institute and, outpatient programs were there with community programs, you could say, hey, when we're designing this program, I can't really call up the senior center and be like, hey, that 1 day a week class, it really needs to be 3 days a week. And this needs to be your curriculum and whatever. And, because it's not my senior center. Right. And they have their, they operate the way they operate, and they have their volunteers and their funds and whatever. Right. So, but at the Seven Oaks Wellness Institute, you could, So
what you're saying is you just need a $25 million donor to step forward and be like, I'm all about this.
Yeah, yeah. Like they've
like,
actually,
it's been done. It's been done.
So this model has been replicated in the United States several times over, and like, people come from around the world. Like, I think quite a few locations in China as well have kind of made their own wellness institutes, and they have everything. Like, they have the intake forums, they have the programming, they have the, like, kind of the funding models and all that stuff. So they also offer private services as well. So it's like that's
awesome. Like a one-stop shop. I love that. And you talked a little bit about the importance of strength training for you, but also just I mean, I'm not an expert in this area, but I am getting older, and I want to be able to move around and not fall.
Totally.
And you're right. The impact of falls on the health system is absolutely significant, not immaterial. But I think we're learning collectively that strength training is really vital.
It is.
To preventing not just cardiac events, but also these falls, which can be, in some cases, the end of the line for folks. Yeah. Cool. Very interesting. Well, let's manifest that. I think that would be a remarkable, I know we're working on some programs here in Kelowna in collaboration with the YMCA of the Southern Interior. I know that there's a really strong desire to bring these programs and integrate this knowledge that we're starting to get with regards to longevity and prevention. It just takes time, and obviously it takes resources, as you've noted. And thank you for sharing that example, that model, because I do think that one of the things that we are trying to do with this podcast is not just focus on the acute side of care. You referenced our first podcast. That was the one with Ali, our CEO. And we're really trying to balance the service that we provide to the community in terms of funding, so that it's not just solely focused on the acquisition of amazing life-saving equipment, like the stuff in the ambulances and what we've got in the cardiac cath lab, right?
Yeah.
But also some of these programs in community that help keep people out of hospital.
Totally. Yeah.
Yeah. So I love that.
Keep people out of the hospital and save lots of money.
Yeah.
Right? Like
well,
$10 billion a year is a lot.
Absolutely.
Yeah,
also,
for
better
Canada,
quality of life for people. If we're going to talk about health,
totally.
Let's talk about health, not sick, right?
Yes.
Yeah. We're drinking the same Kool-Aid, Dan.
Yeah.
And you have one more. You were just telling me this before we started recording, and I love it so much.
Yeah. So it's I think lots of people know about the blue zones, like the cities or areas around the world, populations that live the longest, healthiest lives. So the fellow who did that research was Dan Buettner, and he was on a podcast with Simon Sinek recently, where they were talking about changing the environment to change behavior. So they're talking about how changing behavior is hard, and it is. So in these blue zones, people have purpose, they have social connection, they have activity, like physical activity, and they have drawing a blank on the last one. Oh, healthy diet.
Yeah,
so,
I was going to say
healthy diet. Yeah. So he looks at how the environment kind of shapes behavior to provide these things. And he's been contracted by large insurance companies in the United States to set up blue zone cities for the end of like the end result of saving them money. So the insurance companies are spending too much on healthcare.
Because it's always about money, but like
it kind of drives a lot, right?
The side perk is healthier communities.
People love living in these communities and they're happy, and like real estate values go way up in these cities, and people want to be there. So they have all these markers that are measured by a third party, like reduced BMI, reduced hospital visits, like all the things you'd associate with good health.
Right.
So I think back to falls, and in Canada, we don't have building code that says we need grab bars in our showers or bathrooms. So falls cost over $10 billion a year. We know that a higher percentage of people fall in their bathrooms, especially around the showers. But we haven't changed building code. There are experts, researchers in occupational therapy and physiotherapy who say we need these grab bars and it would, be good for everybody. But the shower manufacturer lobby always wins. So we haven't changed that. And that's an example where we could change. So this Dan Buettner would say, in my blue zone city, all the showers have all the bathrooms are up to code, and they have, grab bars here, and here.
Wow.
So changes like that, right?
Yeah.
He didn't talk about that, but it just kind of, that's what I thought of.
That's what Dan would do in his blue zone city.
Totally. Yeah.
That is so cool. I have learned, I don't know a lot about the blue zone stuff, but I'm going to definitely go listen to that podcast. But one of the areas that I'm curious about, maybe I talk to your wife, the dietitian, right, is the nutrition, right?
Yeah.
And like these blue zones are markedly more healthy in all kinds, as you've mentioned, all different sort of areas, biomarkers and such. But they were talking about, there's a bit of a debate, is like, they eat really well, but they also eat together.
Yes. Yeah. That's part of the social part.
Yes.
Yeah.
Which is, and you've mentioned a little bit about these classes and bringing people together that have this connection with a particular medical event, condition, and the power of connection and community.
So that Seven Oaks Wellness Institute, they have, healthy cooking classes, where you have groups of people coming together, and, how do you, the best way, how do you shop for food at the grocery store, and like, things like that. It seems simple to talk about it and say it, but
I know.
Yeah.
I know. I think, it's another big plug for engagement too. I think just, if you've experienced any kind of medical crisis or medical event, there is this opportunity. Now you have a new community of folks that you're a part of. I mean, my varietal of medical crisis was breast cancer, right? But now I sort of have this community of other women that have navigated that, and the connection piece has been really important. And you've kind of touched on that too. So thank you for sharing. Very inspiring. Maybe we can sit down and map out our blue zone city.
Yeah. So the one city like that this fellow talked about on the podcast, I think they saved $250 million in a year, like 4 years into the blue zone city. Yeah. Yeah. So yeah, it's interesting that it all came about because of money, but yeah. And like they also talked about how much is spent on healthcare in the United States every year, and it's astonishing.
It's not a bad angle, like they say, if you want to change, first you got to learn how to play the game, and we live in a world where the game is money, right? Save money, make money, right? Yeah. So I don't think it's a bad angle, but as I said, the side perk is these incredibly healthy,
seems like happy people, thriving people. Yeah.
That's awesome.
Yeah. Sounds like they eat really well too. Like he talked about the evolution of like they're eating the same food that they would have been eating like generations ago. Yeah. And the food kind of came about the way it is because it's the tastiest, easiest to cook, and like simplest. Like,
I know.
But tastes the best. Yeah.
So the answer to all of our problems is to get off our phones and our devices and just eat the simple things and go for walks and lift heavy stuff.
Yeah, he talks about technology in there too. Yeah. I know.
Yeah. But I think the more we talk about it, the more we normalize it, right? It's like, oh, okay. I'm always in a constant negotiation, let's say, with my family. And listen, I'm not perfect. I'm on my phone. I'm on my, work. I'm on my computer, all that stuff. But being able to have some discipline around, okay, let's put that aside now. And
yeah, totally. I actually just ordered myself a light phone.
Oh, what is that?
So it's a phone. They're made in they're a company from the US, and it's a light phone. It's a phone that it's simple. So it has a calculator, it has an alarm, it has you can put in notes for yourself. I think they'll have a pay feature at some point, like a wallet. Yeah. You can send text messages, you can make phone calls, and you can get directions.
Calendar?
I don't know if it has calendar. Ooh. Yeah.
Okay.
Yeah, I like a paper calendar, but yeah. And then I think they're going to maybe have a Spotify, like a light version of Spotify as well.
But not all the crazy apps.
No web browser, no apps, no social media. Yeah. So they call it like a phone that respects you.
Oh, I love that.
So I guess, and then I would listen to this podcast and I'm like, oh, perfect. I'm changing my environment. Yeah. Like I can change my behavior. Yeah.
And you know what? That's what they say. It's like you start with what's closest to you, which is yourself. And then it just sort of like seeps into the people around you. And then it sort of seeps a little further into your communities. And this is how we do it, right? Yeah. That's how we do it. What impact do you hope that your story and sort of sharing some of the things that you're curious and passionate about, what impact do you hope to have on you?
I mean, I hope people can be healthy and happy ultimately, right? And avoid having a heart attack if they do have that hereditary, like if they have those risk factors, and knowing about it, like you don't know what you don't know. So yeah, just the awareness piece, I think. Yeah. Those would be the big ones. Yeah.
I have thoroughly enjoyed chatting with you. I could probably go on for another hour, but we can't. We're not allowed. But But thank you so much for making the trip to Kelowna this morning.
Yeah. No, thanks for having me.
Yeah, it's been a really interesting conversation. I really appreciate you sharing your experience. I do think that it will help people to understand that there are options out there available. This isn't just a podcast for people that have had, a cardiac event, but also for people that could be at risk.
Yeah. That's ABC. One of the slideshows one of the slides talked about how heart attacks the rate of heart attacks is going down in elderly people. But the rate for younger people stays the same. Like it just kind of stays the same. So my hope is that changes. Yeah.
And that would make sense too, especially if in younger people, heart attacks are caused by hereditary factors, like you said. But even though you're sort of set up with the conditions, it doesn't necessarily mean that you're going to have the event.
Yeah, totally.
And that's what you're talking about.
Yeah.
Right.
It's preventable. Yeah.
Well, thank you, Dan. It's been awesome to chat with you. I wish you all the best and go, I don't know, like ski the mountains and ride the bikes and do all the things.
Yeah.
It's been great to have you.
Yeah. Thanks. Thanks.